good evening everyone. Today we have Dr. Mayur Khairnar from India with us. He has completed his BDS and MDS in Periodontology and Implantology. He is also a fellow and diplomate of ICOI and currently pursuing PhD in dental implants. With over 26,000 successful dental implant placement, he specializes in graftless immediate loading solutions. Moreover, there are 12 international publications and multiple patents to his credit. He has conducted clinical workshops and trained clinicians globally. Dr. Khairnar is a pioneer in advanced techniques, including engagement of implants in pterygoid, zygoma, nasal floor, and lingual cortical with bicortical engagement. The Quickdent company is designed to overcome complications and offer graftless solution with a lifetime warranty and durability. It also offers hope, reliability, and excellence. So now without any delay, let's talk about the topic of today's session, which is graftless solution in severe jaw bone atrophy to improve the quality of life, a true endpoint for any implant treatment. So basically, this severe jawbone atrophy represents a significant challenge in dental implantology, often necessitating complex grafting procedure to restore the bone volume required for implant placement. Traditional bone grafting techniques can be effective, but it is invasive, time-consuming, and associated with increased morbidity, cost, and patient discomfort. This underscores the need for alternative approaches that bypass grafting while achieving successful implant outcomes. A graftless solution for severe jawbone atrophy offers an impactful approach to improve patients' quality of life. By utilizing advanced techniques such as zygomatic implants, or you can say tilted implants, or immediate load protocols, clinicians can minimize treatment complexity, reduce recovery time, and enhance patient satisfaction. So in this webinar, you will learn about the role of graftless solutions in managing severe jawbone atrophy, highlighting their potential to redefine the standards of care in implant dentistry. So before starting this session, let me tell a few points to all the attendees that if you have joined live and have any queries or questions, you may put your questions in Q&A box and it will be answered accordingly at the end of this session. Now I would like to call Dr. Mayur for sharing the screen and for talking about his topic. All over to you, Dr. Mayur.
Thank you, Dr. Shriya, for such a brief introduction. Thanks, Dentist Channel Online, for inviting me for this webinar so that I can enlighten you about the topic of how we can solve a jawbone atrophy cases with a graftless solution. Moreover, that is just not a solving case, but how we can improve the quality of life of the patient, because that's what patient comes from. So first of all, I'm very sure all of you are very much excited for this webinar, and I will be very happy if you are active with me and you are, there is a comment box over there where you can put down your questions, and also you can be in touch with me. You can keep responding me yes, no, whatever it is. Okay, so first of all, I would like to understand how many of you believe that patient comes to us for teeth and a good smile, but not for the implants. How many of you believe that? Do patient wants implants? No, definitely they don't want implant. They want a good smile and teeth. I am very sure. So put down yes into the comment box so that I will be able to see or you're responding with me. Okay. Secondly, how many of you think that if we can deliver a treatment plan which is directly tangible to the patient's final treatment outcome, we will be definitely improving their quality of life, and thereby we will be getting a more referral in our practice, and definitely that will boost our practice. How many of you believe that? Okay, so if we just work for something like getting a treatment done, that's not going to work. What is going to work? If you are making really changes in people's life, definitely that is going to be going to be reflect in your practice as well. How many of you believe that? Perfect. And more important, how many of you want, if patient coming to your practice, how many of you want that your patient should be achieving like what like all these patients which you see on the screen, they should be able to achieve if they have no bone in their mouth or something like no teeth in their mouth and the bone is also atrophied, and these patients, all these atrophied patients are achieving on 7th day or 5th day of their treatment. How many of you believe that would be amazing, I would say value addition to your practice? How many of you believe that? Perfect. So my friends, I, Dr. Mayur Khairnar, today in this presentation, I'm going to cover the methods of doing graftless solutions, and how by which we can improve the quality of life of the patient. Okay, and so before addressing what is the atrophied bone, you need to understand. I'm going to talk about total full mouth implant reconstruction cases, and for that we need to understand what kind of bone is this. So for what x-rays you see now is nothing but an abundant bone cases. Well, this type of bone case, not a problem. They have abundant bone. We know patient don't have to undergo any kind of bone grafting, and such cases can be easily managed. Well, in 99% of the studies, these cases, whatever you've been seeing on the research, these cases are usually accepted, and all the rejected cases which are not included in the studies are all those atrophied cases. They are never included in the studies. Okay, coming to this is again a moderate bone cases where the sinus are expanded, where the posterior bone is having a less height. This is called a moderate bone cases. What is called severe resorb bone cases, where there are height in the premaxilla is very less, okay, maybe around 8-10 millimeters height, and posterior is absolutely resorbed, whereas same in the mandible. Okay, the posterior aspect of the mandible is also quite resorbed. What is highly atrophied cases? These are the cases where the bone in the maxilla is absolutely close to negligible. Premaxilla and also posterior maxilla have no bone. Same way in the mandible, the nerve is almost at the crest. These are all atrophied, highly atrophied cases. So basically in this presentation, what was the thought? My thought was, when I used to see a lot of research article about improving the quality of life. What I mean by quality of life, oral health related quality of life of the patient. So all the presentations were including initial two types of bone cases. That means abundant bone cases and always moderate bone cases, but not many cases, many research were including this kind of patients. So I would say these patients were already rejected. That means we can consider them into the failures, right, if they are not included into study. So we did this particular studies where we have we evaluated the patient's true endpoint, means what our treatment have given result to the patients, not just the surrogate endpoints. Okay, so what is the difference between true endpoint and surrogate endpoint? It evaluate the efficacy of any treatment. So true endpoints is nothing but it is a patient-centered outcome. Okay, and surrogate endpoint is nothing but a clinical, a disease-oriented outcome. Now, what exactly the true endpoint is? Nothing but it is showing whether your treatment is really changing patient's quality of life or not. Whereas surrogate endpoints are nothing but a clinical marker or a clinical indicators. Let's say in our dental, these are the true endpoints. For example, pain. A patient comes to us for a pain. We relieve the pain. Yes, we have changed the some discomfort which was having to the patient. We have changed that, and that was nothing but a true endpoint. However, surrogate endpoint means what you see, the thermal testing, electric testing, all those parameters which you use to assess the pain. Okay, so this is the difference between true endpoint and surrogate endpoint. Say example, in dental implants, the failure and implant loss is going to have a direct impact on patients quality of life. Okay, whereas a millimeter of bone loss or a little bit of peri-implant bone loss or maybe some soft tissue recession, this is something where we can consider it as a surrogate endpoints. Okay, so what we measured in this particular study is nothing but a true endpoint of the patients. Okay, so and these were the certain objectives of our. So all objectives were basically to meant to improve the quality of life of individuals, especially with the resolved jawbone cases. So I'll be presenting you study, and after that I'll present you a lot of cases where we have literally changed the people's life. So we have assessed more than 208 patients between 2017 to 2022. Okay, and who have undergone full mouth cases, and those who were kind of atrophied cases and kind of or maybe a resorb bone cases, something like this. Okay, all majority of they are periodontally compromised. We also included medically compromised patients like diabetes, controlled diabetes, high blood pressure, everything, completely edentulous cases. So there was nothing like other than absolute contraindication. We included all type of cases in our studies. Okay, and all the cases were done with the immediate loading. Now, so we use Quickdent, particularly Quickdent dental implant system. So all the particular designs were used for the study. So first three designs which you can see are the two-piece implant design. So first one is the zygoma, the second one is TPR designs. I'll be speaking on this particular topic, and these are the single piece implants. So in my opinion, okay, I prefer to use more of a two-piece implant. Single piece implants are specifically used for the cases where it is absolutely not possible to place two-piece implant. There are certain indications for that, but yes, all these implants were used. So I'll give you a brief orientation about each of the design. Okay, so what we assessed in a quality of life, oral health related quality of life, first was an emotional and anxiety of the patient. All these parameters were used, like anxiety at whether the patient is feeling attractive, unhappy, or depression before the treatment and after the treatment, immediately, like in 6-7 days, and after 1 or 2 years of follow-up. Okay, we also check for oral health of the patients, and we also check whether after the treatment, whether their environment, like their social circle, their family, friends, how the life have been changed around this particular parameters after the treatment, after receiving a full mouth set teeth, and what they expected out of the treatment, whether they are satisfied or they're not satisfied. Okay, and of course we also check for the chewing function, because the patient wants to patient want to eat well, patient want to speak well, and of course want to smile well. So we also check for all the type of function. So what we found that before the treatment, maximum patients were emotionally unhappy, their social circle was affected, and their chewing, their speech, majority of them, it was all affected. After the treatment, on 5th day, they started feeling little confidence, but after 1 year and 2 years, there was a tremendous improvement in this parameters. We also checked it through the indices, and all these were questionnaire based and interview based clinical study. So we found that they used to feel handicapped before the treatment. Majority of teeth were missing. Now, which has been totally eliminated. Okay, after the treatment, there has been tremendous improvement. The physical pain, functional limitation, functional discomfort, social disability, everything was much improved. Okay, now what any full mouth implant cases, if you see the image above me, it's usually in this fashion where there is a cantilever, but in our cases we almost eliminated all the cantilevers in maxilla also and in mandible also. Okay, so there was no cantilever in our cases. This was the most important aspect, so that we can have a longer durability of the prosthesis. Majority of the cases were screw retained, and they were done with the Quickdent implants with a particular all the options varying from 0 degree till 62 degrees with this particular designs. Of course, majority of the cases were done with the digital protocols as well, and this is a screw retained option. Okay, so I'll show you this particular design, which is Aussie. Usually this is an active design, and here you see even 3D4 type of bone with the one drill only, I was able to place the implant. Of course, we have to reset that. This is implants that currently have been wet. Yeah. This is an active bone. This is an active implant. And because it is a D3 D4, one drill is more than enough to place this implant. But if it is a D2 bone, D1 bone, I will recommend implementing as per the protocol. You can observe expansion of the bone also. Okay, this implant was also used. We also use cortical TPR design. This is specifically having a crestal area which is polished, perfect for a periodontally compromised dentition. For the area where there would be a chance that crestal part of the bone may get exposed, where you have to worry about placing a graft and membrane and then wait for a long period of time. So this can work as a one stage and also a two stage implants. The tip is polished, so we can engage the basal bone, or maybe second cortical bone engagement is possible. The threads are very active, so it becomes a self-tapping implant itself. So the advantage of this particular design over the previous design is that even in the most thinnest bone, it is possible to expand, and in thin ridges also, with one particular drill, this works like expansion screws, and it condenses the bone overall. Also, it expands the bone, so even in the thinnest possible bone. So you can see this particular bone is of just 3.5 millimeter, and we are placing the implant of 3.5 millimeter with one particular drill. Okay, so we don't have to worry about bone exposure. Of course, the such bone expansions are possible in D3, D4, and sometime in D2 bone, but not in D1. So D1 bone, we definitely need more osteotomies. Okay. Of course, we have used in some cases zygomatic implants also. So this zygomatic implant have a polished surface, which is body. Okay, and the crestal, the apical area is totally rough surface, which is equivalent to the body of the zygoma, mostly 12 millimeters. So that's the best part. So periopathogens or perioimplantitis related issues are close to minimum because of the polished body of the zygomatic implants. Okay, so all these type of implants were used in similar fashions, where we avoided cantilevers in maxilla and mandible. Okay, so this is one method by which TPR implant can be used, and we can avoid the cantilever. There is another method where we can place a standard conventional like Aussie-like designs, and in posteriorly we placed a TPR-like designs, and we gave screw return options like similar like to this X-rays. Another possibility is where we used is using a single piece implants where zygoma was indicated, but we avoided that because patient was not ready or medically compromised. So we use flapless one piece implant in upper jaw, if you can see on the left hand side, and lower is screw retained. And on the right hand side of my screen, you can see it complete. All implants are polished implants because the bone is absolutely very, very, very thin. If we want to avoid placing this implants, the only options left out in upper is the quad zygoma. Now patient don't want to go for quad zygoma, then that's why this option is also another option which could improve the quality of life without touching the zygomatic bone of the patient. Okay, and now this is more than this is operated in 2018, so this is a long case right now. Okay, so all these fashions, the permutation combinations were used. Even in most resolved cases, we have given we have avoided cantilevers in the lower jaw, because with the quad zygoma we can and pterygoid implants we can easily avoid cantilever in maxilla. But the problem is the same in the mandible. So here in mandible, in certain areas we have done a buccal nerve bypass and also the lingual cortical engagement, so by which we avoided the cantilevers in mandible also. So what this particular technique, my 24th, I am coming up with another webinar. There will be covering up all these techniques in details, so stay tuned for that as well. Okay, so I'll show you one case where you can see his oral health related quality of life. He was having compromised chewing, of course poor smile, low confidence, his speech was affected, social interaction was hampered, professional life was hampered. Okay, see the bone, see the amount of bone. There's a high amount of atrophy is there. In anterior, I think only say around 7 millimeters, 8 millimeters width is there, but height is only 6, 7, 8 millimeters vertically. Okay, so this is a technically very difficult case to do with the bone grafting and all this stuff. But however, we did this case with a cortical TPR implants, zygomatic implants, and also with the pterygoid implants. Okay, and in the lower jaw, you can see on the right hand side, we did something called nerve bypass. And on the left hand side in the lower, we engaged the lingual cortical engagement, and we did the immediate loading of this particular case with a good amount of follow-up. And this is the patient's before and after, and this is the smile of the patient's day 1 versus day 5. So there has been a tremendous improvement in his quality of life after the treatment. And what we could find that, he was able to chew well, he was able to interact well with all his colleagues, his social circle was quite glorified, and he was very happy. And in fact, we have referred us 2 3 more patients again. He was from UK, basically. He fly down from UK for this particular transformation. Okay, so that's practically possible. The processes which we gave was a lightweight process, so that all soft loading will be happening on the implants, and we will not worry about excessive loading on the implants. Okay, now coming to this particular case, see this girl, what she has done. She has not done anything wrong in her life. She's suffering from this kind of problems, severely periodontally compromised dentition. Okay, her life is compromised. Her college, she cannot interact with the patients, interact with the friends, sorry. In her confidence is pretty low, speech is affected, everything is compromised. Okay, see her bone again. You can see absolutely compromised bone is there in maxilla and mandible, everywhere. Okay, so here we decided to give any chance. Our intention was to give screw retain process to the patient. So any chance, if in future if patient any kind of maintenance, we can retrieve that process and give patient a fixed teeth. Okay, so with help of zygoma and pterygoids and nasal implants engagement and all this stuff, we restored her case, and this is what we got the follow-up of the patient. Although we treated this case into 2020 one, I think so. Yes, 2021. Now this is more than 3 years, but we have a 1 year follow-up of this patient. This patient came for a follow-up 1 year after, and this is a day 5 of the patient. You can see, compared to day 1, patient is chewing because she got a beautiful teeth. She is chewing now. She is able to chew properly. And because chewing, she could smile well. Can you see the amount of confidence which she has gained? Look at her smile. She's looking absolutely wonderful. So she got a wonderful smile. She's very happy, and I'm almost, you can see.
What is love exactly?
In this particular thing,
it's putting someone's needs before yours.
Smile.
Wow.
It's just not a smile. It's a tears of happiness.
This was my
It's
key
easy to
today.
make someone smile. We are
How was
definitely
yours?
do that, but it's very difficult to get someone, that tears of happiness which you can see, because this is something where you can make real changes in quality of life. So this is that kind of a work we should do, and we can easily, improve such quality of life of patients with certainly such technique. Another case. This is again the same. The lady, see the periodontally compromised dentition. All teeth are flunging out. Her aesthetic appearance is totally compromised. Lips are incompetent. She's unable to smile. Oral health, bad breath, unable to face to husband. Okay, this type of problems patient do suffer. Female patients. Okay, but see, then all these things, small things matters if you are really working on changing their quality of life. Then we assess all totally periodontally compromised dentition. All the bone looks good, but anteriorly the bone was very thin, almost close to nil. You can see in the middle section, absolutely thin bone. So we decided not to go for grafting, because again we were a little concerned about our oral hygiene practices. Lower jaw bone was quite decent enough, but height is, see in the posterior mandible, the height is just 6 millimeters. You can see that. Okay, 5.7 millimeter height is there, or maybe 8 millimeter height is there. Yeah, 8 millimeter. So short implants, yes, but then you'll have to wait for long period of time. We finish this case in maybe around 3 days to 5 days. Okay, so this is before and after. After extraction, we place the implants. So we avoided placing implant in the anterior premaxilla, and we place the implants. The long implant which you see in the lower mandible is nothing but the basomandibular implants. I'll be speaking on this tomorrow in the next webinar. So how to place this, everything I'll be covering in the next webinar. So definitely do join for the next webinar. So this is the post-surgical healing on day 1, day 2, and this is the post-treatment. We gave her transitional prosthesis. This is a transitional process given to the patient because we were expecting heavy amount of shrinkage. And this is the day 3 post-treatment radiograph, pre and post of the patient. Now, when the patient came after 1 year to change the process or get reline the processes, this is soft tissue healing. Can you see the amount of hygiene control with the patients having with this? Okay, so that's fantastic because the implants are polished, the multi-units are polished. Chances of peri-implantitis is close to minimum if patient can maintain it well. Okay, so this is the healing tissue of the patient after an year, and that's what is the patient smiling after. So even her quality of life changed tremendously. Okay, are you getting it? Lovely. So this is the now 5 years follow-up of the patient. Patient is enjoying. She's very happy. That's why I'm showing you a long-term follow-up of the patients. This is again a patient. The main problem was she was not able to face her husband. So her husband decided to take her to me once, and her husband gave her a Diwali gift. This year you will smile beautifully. Okay, so that was a problem. See, her anterior, because the teeth is flunging around like the Spider-Man, so there is a huge defect there out there. You can see this area is a huge defect on both the sides, right and left. So there is technically only two sides where I can place implants in the premaxilla, that is in the central incisors area, and one is zygoma and one is the pterygoid. So only 6 sites I have found in our maxilla. That's it. Very atrophied case. We finished this case in 5 days, and this is the follow-up of the patient after 2 years. X-ray of the patient. This is before and after of the patient. Because of this plunging prosthesis, she lost a massive bone in canine region, but anyways, we didn't place any implant in canine. So this is the lightweight prosthesis of the patient. This is the patient before and after. You could see a drastic transformation in her smile. She's very happy. This is her husband. So he gifted her smile, so what she achieved is attention of her husband. That is also very important. That is also improving the quality of life. Am I right? I hope ladies can relate it very well, right? So social interaction, everything, all these parameters were evaluated. She is happily achieving, she's smiling well, everything is there. So that was the case of another case. But the problem was he was unable to afford too much, and of course he was medically compromised. So we decided to go ahead placement. In his case, we decided to go ahead with a restoration in the maxilla with a single piece implants and mandible with a 2-piece implants. So that was the bone over here. See, height is just 6.3 millimeters, width is 2.3 millimeters, 3.4. You can just see the width and height in maxilla and mandible posteriorly. See, okay, absolutely thin bone. So here we decided to go ahead with a technique of single piece implants, and all these zygomas are placed flapless, by the way. So these are flapless zygomas, and flapless pterygoids were placed, and lower we did the nerve bypass on the posterior side. Okay, now we gave something called transitional teeth in the lower jaw without any metal framework. So my friend, I'll repeat again, whenever you're doing immediate loading, you should have a rigid splinting of the implants. Otherwise the implants can the process can fracture and your implants can go wrong, go for a toss. So for example, upper jaw, there is a metal frame, so it is rigidly splintered. Lower jaw, definitely it's not. So what happened? This is the patient before on day 5th. The total change is there. So what happened when patient came after, certainly after a year or something like that, it got fractured in the 3rd quadrant because there was no metal frame inside, and they were supposed it was a graphene process. They used to claim you don't need any metal frame inside, but yes, we were the first to do this case in India with the graphene material, but then it breaks. So after that we started using metal with the graphene as well. Now after this we removed that implant, ailing implant, we changed implant to the another implant, and we gave a PFM process to the patient. So even though the process was ailing and we had more than 4 implants, we could survive and we could change just 1 implant and change the processes. So if it is an all on 4 or 4 implant cases, 1 implant goes, everything goes for a toss. There is no possibility to restore it. Here is in case where we are placing 6 implants, you're already 2 implants, little extras and more secured. So your cases is more secured with more number of implants. That's what I believe so. Okay. Now this is the same patient. You can see he's eating on day 5. Observe him. Okay. What he says after certain period of time.
इम्प्लांट
After
करवाने
4
से
years,
पहले
observe him. He's become
वज़न
chubby.
बहुत कम था, 42 करीब केजी के आसपास था।
42
और
kg he was
इम्प्लांट
before
होने
the
के बाद
treatment.
अभी 4 साल के बाद मेरा वज़न अभी 55 केजी के आसपास हो गया है।
So my friend,
मैं
from
अच्छी तरह
42
से खा
kg
पी
to
सकता
55
हूँ, और
kg,
मेरा
55 kg is
बॉडी
not
लैंग्वेज
overweight.
भी
It's a
अभी
normal
4
weight.
साल
He
पहले
was
से
very
भी
underweight.
अच्छी
So
तरह
from
से
42
सुधर
kg
गया
to
है।
55
मेरे
kg
को
he
इससे
gained his
बहुत
weight. That means it is
अच्छा
having a
लग रहा
direct
है।
tangible effect on the patient's quality of life. You're getting my point? So patients, this is 4 years of follow-up. Okay. And I think now we must be having more than 5-6 years of follow-up of this patient. Okay. So we have definitely worked on improving the quality of life of the patient. Okay. Now another case. Now this patient got some implants somewhere done where this is kind of I don't know, this is some screw implant or something like that, and it got jeopardized. They were left out with no other option. Here, a patient was absolutely medically compromised. I would like to show this case because this has also improved quality of life of the patient. So here we place the implants um, uh, in anteriorly in some areas where there was bone available, zygoma and pterygoids. Lower we didn't touch anything, okay, because lower was stable. In fact, today only I got a call that she needs to get her lower treatment done today, this morning. So I hope surely we will solve her case. So we did this follow-up of the patient. Now it's more than 2 years. It is practically today it will be more than 3 years. So this is the patient before and after. See the confidence of the patient. She is a school teacher, and you know how particular the teachers are, you know, the school teachers. She want her treatment results to be absolutely accurate and all the stuff. She tried achieving even the sandwiches, and she is absolutely very happy. So all these success stories are there on my YouTube channel. If anyone want to access, you can see that. We work only on improving the quality of life of the patient. She's absolutely very happy, right? She is her before and after, tremendous improvement in her quality of life. She is very happy. The lower treatment now, which has been done by someone else, so we will also address the lower treatment if there is any concerns with the lower. Okay, another case, severe class 3 jaw relation, supra erupted lower teeth, everything is bone is also very thin. Okay, confidence is gone. As usual, the same stories here also. See the bone width is only 1.6 millimeters, somewhere it's 2.3 millimeters. Okay, so there is something called palatal placement. Again, this technique I will address in the next webinar. So we use those particular techniques to place the implants. This is called palatal placement. We use zygoma and we use pterygoids. Okay, and we restored this case certainly, and this is the follow-up of the patient for more than 2 years now. This is the patient before and after. So we tried to eliminate her, you know, class 3 relation to as good as class 1, but still she is very happy with the results as of now. Our social confidence, the smile, social interaction, everything, achieving efficiency is much improved. Okay, this is another case where the patient is absolutely wobbly, denture is there. She's been using dentures for 25 years, poor smile, everything. Okay, here this case we did nothing but a quad zygoma in the upper jaw, but it was supported with pterygoid, so we avoided the cantilever. And lower jaw we placed 4 implants in the anterior intermental foramen, and 2 implants to bypass the nerve. So this is the follow-up of the patients after 2 years, and patient is still stable and good and happy. This is the smile of the patient before and after. Her quality of life as well very well improved. So in some cases it is practically impossible to do the nerve bypass cases. That time we have also used something called subperiosteal implants, but it needs a special pre-surgical requirements, like abundant soft tissue should be there, a good sulcus width should be there. Otherwise, it could be a failure also. So don't attempt it unless you have a proper knowledge. So this case, Mr. Purushottam, we did the quad zygoma and we did the subperiosteal implants, and this is the patients before, and this is the subperiosteal implants which has been placed and healed, and this is the patient before and after. This is the process of the patient. Is also absolutely healthy and enjoying the life now. Absolutely resolved bone cases. So for resolved bone cases, my choice of process is always preferably I prefer to go with a lightweight hybrid prosthesis. And today the hybrid process is not the teeth setting one, but it is a kind of a milled prosthesis. You can get it milled from good strong superstructures. So this is a smile makeover of this patient before and after. His again quality of life was tremendously improved. Now this is a very dear case of mine. Now he is a priest. Okay, he suffered from mucormycosis cases. Okay, because he suffered from mucormycosis, he is a priest, so his main source of earning is what? His main source of earning is speech. He speak Vedas, mantras, and all these things, and then he earn. But because of mucormycosis, his speech was highly affected. Okay, that's why his income was totally affected. Financial life is hampered, social life is hampered. Okay, he's not able to cope up well, and so we decided to restore his case. We placed implants in the premaxilla engaging the nasal floor. and of course in pterygoids, and 2 implants in zygoma. Okay, and it was very, that is the time where the mucormycosis, there was no standardization was there for the treatment, there were no protocols for mucormycosis, and implants were used to placed on the maybe somewhere too much on the facially or too much palatally, affecting the speech of the patient or the appearance of the patient. But these implants were placed specifically in the neutral zone of the patient, where the future process will be perfectly placed. If you see the process, the thickness of the process is as good as any normal process. You can see this is a very thin process. You can see now occlusally, very thin process. So we placed the implant. So implant placement, selection of the right length of the implant is also very much important for handling such cases. Otherwise, the speech is never going to be improved. Okay, now I will show you what he says. This will be show. He will be
पर
saying.
आपघात हो गया, एक्सीडेंट
See,
म्यूकोरमाइकोसिस का, तो पूरी जीने की आशा ही खो दी थी।
he
लेकिन
left all
आज
the.
फिर मैं मंत्र बोल सकता हूँ,
He can speak well.
जैसा कि गोविंद ने कहा है कि जब भगवान की कृपा हो जाए, मुकम करोति वाचालम पंगुम लंघयते गिरिम यत् कृपा तमहम वंदे परमानंद माधवम। जब भगवान की कृपा हो जाए तो पंगु आदमी भी पहाड़ी पे चढ़ सकता है, मुका भी वाचाल या वेदांत का विवरण कर सकता है।
Okay, so what he is saying, because of his determination, he got this treatment done. Okay, I am just a medium. I always say to my patients, it's all your determination. Now, the most important thing is what he said was the most important thing. Because of the Almighty, the grace of Almighty, he even a handicapped person can climb a mountain, and even a deaf and dumb can read a Vedas. That's what he wanted to say, that right. So that's what has happened in his case, and it's all immediate loading cases. Okay, his quality of life is totally improved. Look at this vegan patient. He's a pure vegan patient, periodontally compromised, never smoked in his life, never no habit of alcohol, nothing. Okay, but still maybe because of genetic factor he lost all his teeth. Okay, so we decided to restore his case. We removed all his teeth, cleared all the infection, placed the implants.
पा रहा था।
Okay,
लेकिन
he is
इम्प्लांट के
pure
बाद,
vegan.
फुल इम्प्लांट के बाद मेरा 5 महीने में 5 किलो वजन बढ़ गया है,
He's
और
saying in 5 months he
अभी
gained 5
सोसाइटी में
kgs.
मैं बहुत ही अच्छा फील कर रहा हूँ और बहुत मज़े में हूँ।
He is enjoying his life. In 5 months he gained 5 kg, pure vegan guy. Okay, so if would have been a non-vegetarian guy, I can still understand, but pure vegan guy gaining a 5 kg in 5 months. Okay, so that's good thing.
लास्ट टाइम तो आपने कहा था कि 5
Now
महीने
this
में
is after
5 किलो वजन बढ़ गया, तो अभी 1.5 साल में
अभी
आपका कितना वजन बढ़
अभी
गया?
तो बहुत बढ़ गया है मेरा, अभी 10 किलो वजन हो गया है मेरा
1.5 year he gained 10 kgs. Okay, so my goal is not to improve the weight of the patient, but my goal is to restore it back to normal because of the periodontally compromised dentition, inability to eat, your muscle wasting happen, your fat percentage goes down, and you drop the weight. That's where the patient become unhealthy, and they look very, very rigid, so that's a big problem for the patient. So it's very important to focus on their quality of life. Okay, so here definitely his this thing have changed. So now if you must be thinking how Dr. Mayur gives limit of cases, how can he do that? And this is a case we have many candidates in our workshop, not me. Our students have done this. See the transformation. So my friends, it's not just me or I can do it, or some good clinician who can do it. It's even you can do it, but you need to have that kind of fire in you. पुष्पा का कैसा फायर होता है, so that kind of fire you should have in you. So that fire if you have, then you can also make changes in people's life. I had an aim of changing more than 100 people's life in a month, and today we are doing more than 100 with the help, because a lot of my disciples, a lot of my students are doing full mouth cases all around the country, all around the world, in fact I would say. And with the help of these particular designs, some of designs are my patents, and they're doing fantastic jobs. So even if you want all about you and me, right? These basic cytomarks, this is becoming a first so I'm showing you even those cases which is done by our students, and their quality of life has been changed. Of course, we have included even these patients in the study, okay, of those 208 patients. Okay, so of course, we are limited with the time. We have very less time. I understand that, and it is impossible to show you my abundant number of cases of like 208 number of cases in this particular study. But then you can have a look around before and after of certain more cases. This is again another zygoma case where pterygoid was absolutely missing. So we used 2 implants for anchorage in the premaxilla. Again, the periodontally compromised dentition. This is in the lower jaw. Okay, same way we have done pretty good number of cases. In the lower case, all teeth were mobile except the third molar. The third molar were dilacerated. So when extracting was my associate was extracting the third molar, she came out with the tuberosity, the bone. So there was no option left out. So where we used zygoma as a backup implants and we restored this case in the lower jaw. Okay, so all teeth are mobile, but except third molars, right? So this can happen. So you should be ready, because this is like a Kurukshetra. I would say Kurukshetra. There's something called in Kurukshetra, the circle, Chakra view. If you want to get into that, you should know how to come out of it also. So most important is also you should know, and you should have some certain mentor who know how to take you out of it. At the same time, you should learn from him how you should come out of it. So complication will be the part and parcel of any treatment, whether it is an implant treatment or orthopedic implant treatment or a cardiac surgery or a neurosurgery. Complication, unless you don't know how to handle the complication, you should not directly enter. You should enter with the knowledge and with all support. Okay, so that's very important to upgrade yourself. That's why I always say in my lectures and webinars, keep constantly upgrading yourself. Okay, this is again a case, similar type of case where we did a lot of full mouth reconstructions. Similarly, this again few cases where in the lower jaw, absolutely here zygoma was indicated. Patient was not ready for zygoma, single piece, and then so I have no no hard feeling for any particular techniques. So all technique works well. Single piece implant work well, 2-piece implant work well, but you need to understand where it is going to be used at, and use it judiciously. Don't use it unethically. So using a single piece implant in a young girl, I will never do that. But for a patient whose age is more than 75 and to avoid zygomatic implant, I will definitely use it with a proper protocol. See, the margins are also very well sealed. Okay, so it will never fail. But then it has to be used judiciously. So that's very important. So both work well, but how and where to use, one should know it very well. Okay, so this is again a case, absolutely thin bone. See, you can see an anterior mandible bone is very thin. Here you cannot do any kind of block grafting or something like that. It will never mature. But this case can be managed with the polished implants. Okay, so of course I will talk about this when we have we'll be talking on this. So where and how to use this polished implant, many resolved cases. This is my Instagram channel, so you can assess a lot of cases which I keep posting on the Instagram. So you'll get update of my cases on and off regularly. I would like to thank Quickdent Implant System because they supported me with all particular implants and the study materials and datas and everything. Okay, I'll be talking tomorrow. No, day after tomorrow. I think 24th of Jan on 6 p.m. on cortical TPR 2-piece rough surface. Its indications, where it can be used very well, and also specifically about different cases by which we can solve. It's not about just single it's not just about single jaw or full mouth case. It's about how it can be used for anterior teeth restoration, also many more things, cross channel type, so many things are there, which I'll be speaking on this implants. We also will be showing you the prosthetic aspect. That will be on webinar on 26th of Jan, where I'll be decoding. That means I will be explaining about the digital method and analog method, that is conventional method or prosthetic protocols, as well as the surgical protocols in full mouth implant cases, where you can do with an immediate loading protocols. Okay, so all these things will be covered. So we'll be covering, I'll be comparing the digital aspect as well as the conventional aspect of prosthetics and surgeries with this particular on 26th of Jan. Okay, so I would like to thank you Dentist Channel Online for this wonderful opportunity, and I'm really grateful that all of you have joined in the busy time of your practice. So most important message which I would like to give to all the candidates who have joined is, so what matters most is to improve the quality of life, because we as a dentist, we are a scientist, we are an artist. Okay. And more important is, so this patient comes to us for a teeth and smile. Okay, they don't come to us for the implant. So it is very, very important for us to improve their quality of life. I always say, खाना खिलाना पुण्य का काम है. Okay, खाना खिलाना पुण्य का काम है, बट खाना खिलाने लायक बनाना इस उससे भी ज्यादा पुण्य का काम है. So if you giving food to someone, it's a good thing. Okay, but if you are, it's a good deed. But if you are making someone so that they can eat by their own, that's the best. So this is what we do as a dentist. We are in noble profession. We are not just for doing a filling. That is also important, but we are in noble profession to change people's life, and let's utilize that. Don't be surrounded by the negative aura around you. You have a pretty good future, and the golden age in dentistry is yet to come. I was just discussing this thing with Mr. Melvin a few days back. The golden era in dentistry in India is yet to come. So please get equipped yourself and learn and start changing in people's life. Okay, so these are the references to my studies on quality of life, oral health related quality of life indices. And I would like to say again a thank you to a whole team, to Dr. Shreya, to Mr. Siddiqui, to Mr. Melvin, and whole team of Dentist Channel Online for inviting me to give insight about the how to improve the quality of life of the patient in highly atrophied cases. Thank you so much. With this, I would like to conclude my presentation. Thank you so much. Thank you so much.
Thank you so much, Dr. Mayur, for such an insightful and such an interesting topic, because it is it is very hot topic of dentistry, the implants, because everyone nowadays they know about that how much we are concerned about the aesthetics. So I think it is a very important one, and I hope that all of the attendees they must have got some knowledge from this webinar today. So now it's Q&A time. If you have any questions and if you have any queries, then you can put your questions in Q&A box. And yes, as Dr. Mayur already discussed in his presentation about his upcoming webinars, so I will inform you guys once again. The first webinar, upcoming webinar of Dr. Mayur, the title is Preferred by Surgeons, Bicortical TPR Implants in Full Arch Implant Restoration, which is on 24th of January at 6 p.m. And the next one is Decoding Digital and Analog Method to Master Full Mouth Reconstruction with Immediate Loading, which is on 26th of January at 2 p.m. So join this upcoming webinar and learn more and more about implants and its new innovations. So let's see if there are any questions. Kindly clear. Yes, I would like to apologize from all the attendees that I know that there was some glitch with the presentation. We will make sure that from next time, like in the next upcoming webinar, there will not be any such issues. Thank you for bearing with us. And next is thank you, sir. How the certificate? Yes, certificate is possible. We will get back to you regarding this. The next one is this zygomatic approach in your slide? Is the zygomatic approach in your slide? I didn't get
Is
it. What
this
it is?
zygomatic approach in your slide?
What's that?
I don't know. The question is need to be framed correctly.
Yeah.
Yeah, so I
Yeah,
would
you
give
can.
you a brief idea about zygomatic implants. So see, the zygomatic implants can I usually prefer, because the implant has a polished collar of body. So I always prefer to place zygomatic implant with a extra sinus approach. Preferably, more importantly, what is our intention is to get the prosthetic orientation. That means the position of the multi-unit abutment along the occlusal surface as best as possible. So sometime so we try to keep it in the neutral zone so that the prosthesis thickness can be as minimum as possible. Which soft prosthesis material you use? Okay, so coming to the soft prosthesis, There's nothing like soft processes, but yes, when the bone is resolved, we need to use a lightweight processes. So we have something called metal bar. Okay, a metal bar could be, it is called substructure. The metal bar which is substructure could be of titanium or could be of cobalt chromium, and there is something called superstructure which sits on this metal bar, and this superstructure could be of either your regular PMMA, but it doesn't have any life. It could have a reinforced PMMA which is called graphene. It could be a reinforced another type of PMMA which is called multicom, which is available from Redent. And another type of superstructure could be of, we can call it HIPC. This is again a reinforced composite based PMMA. This is also, so these all are the blanks which need to be milled, and it could be fitted on the metal bar. That is something lab people will do. What is the another question?
Another
All
one
of
is
four with pterygoid implant is better or zygomatic implants are better? Of course, it all depends on the indication of the cases. When the bone is not available in the premolar zone, okay, that is first and second premolar, the implant placed in the canine and one into the pterygoid will be having a very long span, so you need to fill that span with a zygomatic implant. So it's all specific, patient specific. But yes, if your implant is coming in the region of the 5, you can avoid zygomatic implant. Instead of giving cantilever, you can give a pterygoid implants. So that's one thing. What's the next question? In your
in your
slide,
slide.
zygomatic precursor
Zygomatic
taken.
precursor taken at least 6-week gap mandatory after multi-unit abutment.
So, zygomatic precursor taken at least 6-week gap.
Mandatory.
No, I didn't get this question again. Can you repeat it? How much will it cost for a patient if they need the treatment? I mean, this is particularly your personal perspective, but anywhere the treatment usually for a full mouth implant usually starts in say around 4,000, $5,000 to 10,000, $15,000. It's up to you. It's up to you. Dr. Mayor, are you conducting any patients hands-on Delhi? Yeah, so be in touch. We there are our dealers over there. We are having a collaboration with few uh, uh, clinicians over there, where we will be coming up with the workshops over there. So be in touch with us about this. Some tip. Next question. Some tip about when you go for buccal bypass, when for lingual
When
bypass. Please attend my next webinar for this. In detail, everything will be shown about this, and I will show you with the two-piece implants more specifically. So same you can apply with the one piece. Which implant is preferable for single tooth or quadrant wise case with a sufficient bone? Is immediate loading possible? Yes, immediate loading is possible by two methods. First is called corticalization of the cancellous bone or condensation of the cancellous bone. That means you placing an implant with or active implant or passive implants, and you're getting a high torque, and you're placing implant in the standard bone. So that means your bone around the implant, the cancellous bone around the implant get condensed, so you get a high torque. This is one method where you're not engaging two cortical bone. Okay, but however, the cancellous bone is sometimes very hollow or very less dense. So this technique will not give you high torque. There we need to engage two cortical bone. This is called bicortical fixation, and by which you can definitely place. You can get 100%. You can get a good torque. Zygomatic precursor taken. Precursor is what is precursor?
next
Sir,
one
in
is
many
sir,
cases,
buccal bypass
bypass.
and lingual
Okay.
bypass. Can you show how you do it?
Okay, that's why I'm telling you in the next webinar we'll be having nerve bypass orientation as well. Okay.
Next one is what medication preferred after implant placement?
Okay, so most importantly, it's not about just medication after the implant placement. It should be before the placement. Evaluate the medical health of the patient. If the patient is having any medical challenges which requires medical antibiotic coverage, so do cover antibiotics at start. Also give anti-anxiety medicines to the patients to relieve the anxiety, and analgesics, whichever is more suitable to the patient. Antibiotics like augmentin is the most suitable. I would say amoxiclav and metrogel. These are the most metronidazole. These are the best common medicines to be used, because this directly acts on the periopathogens also, and also it can give you a good coverage for your surgical procedure. And most least not best, you have to have a complete asepsis of the procedure so that you won't come across implant failure due to infection. Yeah. How do you place implant position and placement in full mouth cases? How do you plan implant position? Okay, so you have seen this anyways. Again, in our next webinar we'll be addressing that. So this is depends on again on case to case. Implant supported prosthesis causes of failure, kindly explain. Most important failure is you're not getting a good torque and still you're loading it, you're choosing a wrong prosthesis. Okay, that is the second failure. That means where the bone is soft and you're given immediate loading with a porcelain fused to metal. That is again not a good option. Another is your process is very active. Because the process is active, the screw loosening has happened, and patient, after certain years, when the patient is coming, one screw is attached and rest of the screw is loose. That's where the implant can fail. So please always do one screw test. That will improve your success rate by much time. And appropriate occlusal scheme to be maintained regularly during the regular follow-up. Medications you used after nerve injury. Okay, so this is you should use, of course, the steroids. If any chances you come across any medical nerve injuries or nerve paresthesia, steroid should be used, and you should use pre-GABA M. This is again a medicines, but of course you should better refer it to the specialist, neuro physician. That would be a best option. Conventional implant versus digital implant, which is best? So I would say both the implants work fantastic. It's all about the indications. Wherever the indication is required, you should use those implants, as I've told you. So I would love to do periodontally compromised cases with none of above. Conventional, not even conventional, not even basal, but hybrid. The cortical TPR is an hybrid implants. It can be used like a basal, and it like with respect to the surgical aspect, and with respect to prosthetic aspect, it can be used like a conventional implants. In single piece implant, did you use welding? No, I never do welding. Welding is something, it hampers the margins of the prosthesis, and definitely a lot of plaque accumulation happens. It is a maltreatment. I feel whoever is promoting welding for single piece implants, they are more into selling of the welding machine. So don't use that. Welding you want to use it on a thick tie basis or a thick titanium cylinders, and make a screw retain process out of it. That would make a more sensible outcome for the patient, prosthetic outcome. What sources of book you read? All the standard books for the implants, like Carl Misch should be on your tip of tongue. That is the best option, book. And there are many other books like Babush you can use. Many books you can refer. So more you read, more you get better knowledge. Occlusal scheme in FMR, we use group function. Moreover, not like a flat teeth, we use a typical group function with a appropriate contacts, occlusal contacts coming on both right and left side at the same time, elimination of the premature contact. Lot of things are there. Occlusion itself is a kind of 2 hours lecture, but I'll give you briefly idea how to select the cases. It is an implant or prosthesis FPD. How to what bone support, what work. So this is the lecture itself. Then case selection is itself a new topic. I am very sure this year we'll be having a lot of topic to cover. I'm sure, Dr. Shreya. So we will be covering up on case selection also. So don't worry about this. My book is on the way. It will be there coming soon. Don't worry. Thank you so much.
Thank you for your patience, Dr. Mayur, for talking about all the questions and taking all the questions and talking about it. And thank you for once again for such an insightful session.
Thank
And
you so much, Dr. Shreya.
stay tuned for the upcoming webinars of Dr. Mayur, and you will get to know more about the implants. And I think the takeaway note, in a simple word, the takeaway note can be, that we need not only to talk about the implant, but we need to also we are also concerned about the quality of life and how to restore the function, how to restore the aesthetics, and overall well-being of the patient is mandatory, is very, it should be kept, it should be prioritized first. So I think that's the takeaway note. And yes, on 24th, let's talk once again about the implants. And thank you so much, everyone, for joining with us. And thank you once again, Dr. Mayur.
Thank you so much. Yeah, thank you so much. Thank you, Dentist Channel Online. Thanks, Mr. Welvin. Thank you so much.